Welcome, my dear postgraduate students. I am happy in taking a class for you after a very long lull. And I am sure that this will be a feast for you people. The topic for the day is eosinophils in health and disease. I shall go to the topic proper. What do you infer from the term a cell in health and disease? What are your comments on it? When a vivid question like this is thrown at us, a lot can be answered regarding the cell itself, its function, the sites where it is produced and where it acts, the lesions it is associated with, the significance, and finally, a compilation of the entire answer. To me, this is an undaunting task. And this helps in evaluating a candidate. Very obviously, you find that the difference between a good, average, and an excellent candidate can be made out from such answers. Let us see our approach to this. Of course, on the screen, we are seeing the favorite eosinophil of ours, a three-dimensional picture. These will be the topics that we shall touch upon. The list is never ending. Coming to the topic proper, this is something that we shall rapidly review. The percentage we all know, 2 to 4%. In India, of course, even a 10% eosinophil is considered as normal. We have got the acid-loving eosinophilic granules. That is the difference between the neutrophil, eosinophil, and the basophil. The absolute eosinophil count being 40 to 440 per cubic millimeter, and the size is 12 to 18 microns. It is commonly associated with Th2, interleukin C2, GATA3, which is a transcription factor, and eosinophilic basic protein. Interleukin 5 is indicated in its development. This is on one side. On the other side, I am finding a list of tissues where it can probably be present. The bone marrow, surprisingly, the medulla of the brain, thymus, any lymphoid organ for that matter, GIT, lung, skin, ovaries, and whatnot. Which means there might be a lesion anywhere which we should not miss in our list. This is a schematic picture of the eosinophil, which I like very much. The nucleus, what are the primary granules, and then the specific or the secondary granules. This is on one side. On the other side, I have got a lot of receptors. You people can go through the list. There are a lot of receptors on the surface. At the same time, you find that this produces a lot of substances, and there are canaliculi and tubules which are delivering the substances to the particular spot. What is strange is, how is it that in a particular condition that this particular substance is being released and it acts at that particular site? Similarly, how is it that the substance that is being released elsewhere acts on the receptor and then activates the eosinophil itself? This is a schematic diagram, but I feel it is useful pondering over it. What do the eosinophils produce? There is again a list over here, and I have highlighted in yellow some substances which are very familiar to us. So much so, it will be easy for us to recollect them. I find that there can be cationic proteins, there can be degranulation, producing the reactive oxygen species, superoxide dismutase, we all know as a free radical. Eosinophilic peroxidation can lead to the production of a peroxide. Leukotriene, it can be B4C4 or D4. Elastase, growth factors, cytokines, any of the interleukins you can name. Tumor necrosis factor alpha, major basic protein, eosinophilic cationic protein, peroxidase, and neurotoxin. So there is an entire list. Whatever you people are familiar with, I would advise you people to kindly reinforce your memory with that so that you do not fumble in the answers. This is again a very, very schematic and down-to-earth flowchart. On being activated, you find that the eosinophil can undergo a degranulation. A lot of granules are present within the eosinophil, and these get released. Also, the DNA is stimulated, which leads to extracellular DNA traps. Ultimately, there can be a lysis of the entire cell, as a result of which we can get cell-free granules. All of these can lead to killing of the pathogens or damaging the tissue. So this can be considered to be a fundamental flow diagram which you people can very easily enact upon. And surprisingly, you find that one of the first reactions I saw was eosinopenia, a decrease in the eosinophils. Probably it is below the 40 to 440 that we have mentioned in the first slide. These can be the various causes for it, and please do remember them. Aplastic anemia, agranulocytosis, Cushing syndrome, steroids, burns, acute shock, or even acute infections can all result in eosinopenia. And the hypersensitivity. The type 1 hypersensitivity, it is supposed to be the mast cell degranulation with the production of various substances. Towards the end of it, in your own Robbins, you would have given the immobilization of the parasites. And this is important over here. Normally, you find that this is the eosinophil and this is the parasite over here. And when the eosinophils are there also, there is a blocking antibody for the immunoglobulins, as a result of which they do not act upon the parasite. But again, there is no cleavage of the immunoglobulin. Again, it does not act upon it. These are two steps where it is defective. On the contrary, when substances like superoxide dismutase are being produced, there can be a degranulation that is formed, releasing the immunoglobulins, or there can be a surface action by IgE, which is very important. And there is a mast cell, subsequent to which we are finding the eosinophils reaching the site. Now, they immobilize the parasite and kill him. These steps we people should be remembering. There is a maturation, migration, helminthic infection is there in most of us, but then it is the long worms that are being immobilized by this. What is the response to chemokines such as eotaxin? What are the leukotrienes that are produced? Major cationic proteins, cytokines, and vasocellular adhesion molecule, intercellular adhesion molecule. This is the next one, the allergic rhinitis. Coming to this particular topic, more than the pathologist or their counterparts, I find that the pharmacist or the pharmacologist has done a lot of work. This particular diagram itself It is about allergic rhinitis. We shall forget the blocking over here and see what is the actual function. So this is a target cell in which you have got some receptors. So there is a leukotriene receptor that is over here, which is being blocked by the antagonist in pharmacology. And again, there is a histamine receptor. Also, this is a mast cell that is undergoing degranulation, producing various substances such as kinins, prostaglandins. What will happen is, this will be the first stage. In the second stage, there is a further activation of the eosinophils and the basophils producing the histamines. And that is when the eosinophils come to act. Probably if these are blocked, there can be a treatment to the allergic disorders as such. That is the theme, but we shall concentrate what the receptors are, what are the substances, and what the cells are concerned with this particular condition. Sinus histiocytosis, of course, is a reactive condition that we all know. So there will be the production of a lot of these histiocytes. There is a widening of the sinusoidal spaces, and surprisingly, there is an increased amount of eosinophils that are filling the spaces over here. And this is a condition of the allergic polyp, which we very commonly come across. What we see is this. So I find that this is the pseudostratified epithelium over here, and I find a lot of these plasma cells and the eosinophil stem cells are being produced in this condition. Allergic rhinitis is one that we shall be mentioning. These lists are being produced for the sake of completion. This is an extremely important diagram showing the relationship between the T cell, the B cell, mast cell, and the eosinophil. The T cell was over here, the B cell, the mast cell, and the eosinophil. Now, what is the relationship between various types of these cells? This is the gastrointestinal lumen over here, and this is the lining epithelium. So you find that there can be a degranulation, there can be an increase in the epithelial permeability. There can be the activation of the T helper cells. Finally, the B cells, the production of the various antibodies, the mast cell degranulation, which can be acting upon the muscle fibers. There is a neural stimulation and the muscular contraction. So you find that these four are being interrelated, which you people will have to mention repeatedly. And eotaxin is one product that is being produced by the eosinophils. So this is an extremely important one, which we shall memorize. And this also equally. So this happens in the lung. The previous diagram was in the G8. So this is the lung, either of it, wherein there is a mast cell. The mast cell produces the various types of interleukins and the tumor necrosis factor alpha. So there is an activation on the ciliated epithelium. There is a release of the eotaxin, and this will lead to the chemotaxis or the mobilization of the eosinophils, which help in the contraction of the smooth muscles, the fibroblasts, and also the mucus production of the epithelial cells themselves. So this is one schematic diagram which we shall be having in mind. Also, the tumor necrosis factor can lead to interleukin 5, which leads to the release of the eosinophils from the bone marrow. This is a superb and a simple diagram which you people shall reproduce. This is almost a repetition of the same. I have just encircled the two sites where the eotaxin is being produced and where it acts. So it is restricted to eosinophils. It is an activator. It can be a chemoattractor, or it participates in chemotaxis and produces the reactive oxygen species. Definitely, it is a participant of inflammation. All the other components, you can go through it in leisure, which have already been done. So it is only a repetition. The skin is yet another site where the eosinophils act. So this is a eosinophil and this is a mast cell over here. And you find that there is a production of the antibodies which can act on the receptors on the mast cells. So there is a degranulation. Also, similarly, you find that there will be the attachment to the receptors on the eosinophils, which can lead to the production of major basic proteins, platelet activating factor, vasoendothelial growth factors, etc. And these again can be enacting the mast cells. So always remember the relationship between the T cell, B cell, mast cell, and the eosinophil. This is incidentally a picture of urticaria just for you to recollect. The next group of disorders we shall be talking about will be Langerhan's histiocytosis. There are other terminologies such as Hans-Christian or a letter-Suey disease. Eosinophilic granuloma is a misnomer. This is caused by an abnormal clone of cells, and the disease itself is autosomal recessive. From the bone marrow to the lymph nodes, we find abnormal cells accumulating, which are activated dendritic cells. The bone and the skin are the various organs which can be affected. There can be the Biber granules, which we shall be seeing in the next slide. An SN red or a peanut agglutinin can be a marker for it. In this picture, I am finding sheets of these histiocytes, and also by the side of it, I am finding numerous eosinophils which have got accumulated. So I think this one is very clear for you people. We shall continue with it. Please do mention Letter-Suey disease in your answers. And this incidentally is the tennis racket pattern, which is seen in the electron microscopy of the cells affected with it. This particular diagram is a good compilation. I had brought in the electron microscopic picture not for explaining the various components of it. I am not an expert on it. But then this particular one we shall and will by heart. It is an excellent compilation, and it mentions the cytokines, the chemokines, and the cationic proteins in a very orderly manner, very easy for us to memorize. So this is a quote about compilation. Every job is a self-portrait of the person who did it. Autograph your work with the excellence. Vince Lombardi. The next disorder will be the Church-Strauss disease. It is a kind of vasculitis, and it can be affecting the scalp or the underlying bone. Initially, there is a kind of ulceration, but then there can be the damage to the underlying bone also. The patient may be having a multi-system disorder. Here, for example, the lungs are being affected, and the blood vessels will be showing a vasculitis. There can be extravascular necrotizing granuloma that can be seen, and these are the clinical manifestations. Usually, it affects young children below 3 years of age. And this again is a vasculitis flow diagram from Robbins, which you people can recollect. In this, what is important is there are the large cell vessels, medium cell vessels, and the small size blood vessels, in which you can have immune complex diseases. There are the various things over here, but towards the end, he mentions the granulomata with polyangiitis, also the eosinophilic granulomata with polyangiitis, called the Church-Strauss syndrome. So this particular diagram can be useful for us in many a situation. This is again a recollection. I find that there is a large parasite, and then there is the eosinophil over here, there is a macrophage over here, and there is the emigration of the cells, there is immobilization of the parasite, the various plethora of mediators that are being produced by the cells. So this particular one you people can recollect. Surprisingly, you find that this eosinophilia is not restricted to the skin or the lymph node or the bone marrow. This is a slide of the eosinophilic colitis. So there is a colon over here, maybe a few goblet cells are seen. I need not magnify it further. You are finding a wonderful infiltration with eosinophils in this. And it is supposed to be an immunological or an allergic reaction. Also, I find that there is a eosinophilic granuloma with polyangiitis over here. So this is a picture of it, the eosinophils, and this is seen in the next slide also, wherein I am finding increased number of eosinophils. Eosinophilic esophagitis. This is an endoscopic picture of the esophagus in which I am finding multiple rings. Look at the rings over here. Normally it is a straight line, but in this case, probably due to reflux esophagitis, there is a constriction in the ring that is being formed. And also there can be a damage to the stratified squamous epithelium. There is an accumulation of the eosinophils and the neutrophils in this particular site. I hope you people are able to make out the eosinophilic granules in this. This is a repetition of the other diagram, but I would like you people to kindly use it anyway. The Scherp-Strauss syndrome is given over here, and this again is the caliber of the blood vessels, and this is the source of reference. This is an easy one for you people to memorize, and the various applications are given in the boxes over here. Loeffler's syndrome. So this is a lateral and the anteroposterior X-ray of the chest, in which I am finding multiple patchy areas of consolidation. There is a bronchopneumonia. And what is Loeffler's pneumonia by itself? I hope you are able to identify this particular trend, courtesy Wikipedia. So it is because of a migratory parasite, in which I will be able to find numerous amount of eosinophils, more than 2000 per cubic millimeter. The next one is a chronic eosinophilic leukemia. This particular slide I have purposely put so that you are able to identify the different lineages or the different levels of maturation of the granulocytic or the neutrophilic series. You have got a blast, you have got a promyelocyte, you have got a stab form, a mature neutrophil, etc. Then, what am I meaning in this particular slide? Look at this one. I have put this only for comparison. I am finding numerous cells which are having the classical eosinophilic granules. One of the fundamental things that you people will have to remember is identify the eosinophil by means of the granules and not by the number of loops. So you will be finding that these are all the committed cells from myelocyte downwards, where you will be finding the eosinophilic or the secondary granules. So it is a case of a chronic eosinophilic leukemia. When it comes to a chronic leukemia, it can be a neutrophilic leukemia, eosinophilic leukemia, or a basophilic leukemia, depending on which cell lineage is affected most. And this, incidentally, I have given it for a recapitulation. There is a myeloblast, promyelocyte, and then the metamyelocyte, myelocytes. So early myelocyte and the late myelocytes. This is followed by the metamyelocytes over here. From the myelocyte downwards, you will be finding the specific granules, and in our case, we are finding the eosinophils in this case. So when this proliferates, you get a chronic eosinophilic leukemia. But then, can you have an acute myeloid leukemia? Whenever a teacher asks you, can you, or is it possible, kindly say yes. No teacher will like to mislead a student. And this can happen in a case of granulocytic leukemia, acute promyelocytic leukemia downwards, wherein you can have a eosinophilic leukemia, or there can be a myelodysplastic syndrome as well. Please do remember these two and mention it in your answers. Our next trend is the Hodgkin's lymphoma. In the Hodgkin's lymphoma, obviously, we find that there will be a mixture, which is supposed to be an inflammatory response. So these are the classical Reed-Sternberg cells that we see, and there can be the proliferation of the granulocytes or the B cells, the lymphocytes over here, the eosinophils, the mast cells, plasma cells, all can be increased. And there will also be the proliferation of the fibroblasts. This incidentally means that all of this is a reaction which can be seen in a case of eosinophilic leukemia. In a case of mixed cellularity, there can be quite a good number of eosinophils, which we should not fail to make. The corollary of it can be whenever you see eosinophils, think of a tumor also. The second one is think of a parasite. So how do you target the eosinophils in a case of allergy? Again, from pharmacology over here, you find that the eosinophils, they can act upon the T cells and they'll be producing the cytokines. They can be acting upon the host defense by means of the various granules, mitochondrial DNA traps, etc. That can be the action on the immune response. So you find that there can be the production of the various mediators of inflammation. Also, there can be a tissue remodeling in fibrosis. So all this can happen by means of a eosinophil. Plasma cell is yet another one wherein there can be the production of high affinity antibodies. So these are the various probabilities of the eosinophils and its functions. There is a syndrome called the hyper-eosinophilic syndrome. I find that there are multiple coarse rashes on the scalp, and also there are hyperpigmented areas which can be seen on the chest and back. The hyper-eosinophilic syndrome, the criteria for diagnosis will be more than 1,500 cells per cubic millimeter. In addition, you find that there will be a eosinophil-induced organ damage that can be identified. Third one is you will have to exclude all the other causes for eosinophilia, such as an urticaria or a bronchial asthma, a drug-induced disorder, etc. And only then you narrow in on the diagnosis of hyper-eosinophilic syndrome. And an alternate way of coming to it is there are more than 20% of eosinophils in the bone marrow. There is a tissue infiltration, and there is a histological evidence of damage because of the eosinophils. So these are the two criteria or two methods by which we can approach a diagnosis of hyper-eosinophilic syndrome. And so creativity is a compilation of things we have seen. What have we seen so far? This is one diagram that summarizes. So you find that there are the eosinophils over here. They act on a number of cells such as the epithelium, the fibroblast, the smooth muscle, the mast cell, and the T helper cell. Also, the mediators that are involved in each of them. They will be acting as a defense against the fungal spores and mucus. Also, you find that these mediators that have been compiled within the box are worth memorizing. I have taken out the most important things which we are familiar with. This particular list is worth its weight in gold. And this is yet another diagram which I want you people to memorize. The eosinophil is over here, and you find that it is concerned with interaction with the immune cells, the helminthic resistance, bacterial and viral resistance, tissue repair and fibrosis, neuroimmune interactions, regulation of the immune system, inflammation, as well as the different parts of allergy. Again, the mediators are given. You can read the mediators from any one diagram, but all said and done, you will have to memorize this particular list. There are different causes for eosinophilia. Whenever we are asked, we fumble at urticaria or eczema or bronchial asthma. This is a very nice compilation which you people can memorize. It can be limited to the lungs or it can be multisystem. So this is one that I would like you people to kindly memorize, and most important lesions have been given over here. In this class, this is the entire panel of topics or the subheadings we have touched upon. So when a question like this is asked for a period of about 20 minutes, you will have to frame your answer in such a way, arrange it either from structure, function to disease, or from organ to organ basis, and perform or present an excellent answer. Thank you.